initially, as the project came together, it was building administrative support. So informing them about the nature of the project and getting their support for you moving forward.
Well, certainly initially that was, there was a lot of effort in that regard. Ours is a hospital-funded intervention, which is quite different than a lot of the quality improvement programs going on locally, nationally, or in particular in, so early on that was a major focus. Interestingly, I think having really key administrative leadership has been essential to our success, because we're working very closely with, our pharmacy team. We're working with care managers, nurses, social workers that are all integrated into usual care, and then we have sort of the add-on components of our program. But having strong administrative support really helps us leverage and move forward. So it wasn't so much getting individual buy-in, but really getting institutional coordination.
Institutional coordination and support so that you could move forward. So you talked about the development checklist and how you've refined that using the PDSA cycle over time.
Yeah.
Has that taken you in any direction that you might not originally have anticipated? Or have you found that the iterations as you've moved forward, both sort of clinically and patient managed-wise, you could have predicted they might have fallen into place or not?
That's a hard question. I think that the fact that we have continual input from the different aspects of our program has really shaped the way that we prioritize the key aspects of our checklist. And so, my clinical work is I'm a hospitalist in the hospital with the resident teaching service, and I also see patients at the Old Town Clinic. So I try to wear as many hats as I can in a clinical capacity, but I don't understand a pharmacist role. I understand, I think I understand a nursing role, but I really don't understand a nursing role. And so really getting input from different perspectives has also been very, very important, and I think has really informed the checklist and informed the intervention.
Certainly, that makes sense. So it's that multidisciplinary perspective and approach that builds it as it moves forward.
Exactly.
Okay, great. Thank you. Rebecca? Talk about barriers.
There was a hand up over there.
Oh, I'm sorry. Yes, sir.
Question. In this era of checklists and writing order sets for heart failure, we generally pick what the guidelines recommend, evidence-based medicine, and then in the patient group that you described, they go through their hospital stay, getting standardized care based on the order set, and then when it comes time to discharge, the patient all of a sudden was scrambling around to replace liquid chloral with a generic statin. You integrate this approach in the hospital and identify those patients early on and carry that through, because it seems the way it's done in the community is there's one set of standards in the hospital, and then there's the scramble so that in essence the medicines are changed on the day of discharge, and you have to figure out what dose is the equivalent.
It's a great question, and I'm going to answer sort of in two parts, specifically around some of the issues of kind of how realistic is it to deliver certain standards around practice, and then what are the realities of care that we can deliver in the hospital, and then the post-hospital realities. Our team has identified early on, we've developed a formulary and developed linkages with clinics so that we're really trying to map out what is this transition going to look like across the care continuum, and how can we be realistic. So we are shifting that change in terms of choosing our specific medicines as early as that first pharmacy consultation, which happens very early in the hospitalization. So we've built that anticipation of that process and anticipation of some of those steps and gaps in care into our program. But I think that specifically what your question highlights is a point that I think is really important to make, which is that, and I think Devin mentioned this earlier, others may have as well, that there are no off-the-shelf fixes. And so really thinking about what others' experience have been, looking at the literature and saying, this is an approach, but then really understanding local needs and letting an understanding of local needs drive local change, I think is important, and how we define local certainly can expand. But
Thank you.
I clearly missed the memo because everyone else has notes on their biggest no. Yeah, it's like you anticipated the question. But I can talk off the cuff for sure. So the challenges depend on which intervention or which initiative we're talking about, but I'll just mention a few. In terms of what the health plan telephonic intervention and the challenge, what that is, why we are doing it, and what those challenges are. The issue around a lot of transitional care interventions is who funds them. Who has the business case, and of course that's changing, and we're seeing that change currently. But from a health plan perspective, we're paying for those readmissions and those index admissions and the readmissions and the ED visits. So it's always made sense from a health plan perspective or a payer perspective to try and do what we can to prevent avoidable readmissions. So here we are, a payer, and we're not delivering direct services. We contract with all kinds of great physicians and groups in the community and hospitals and vendors and pharmacies. But yet we own the single biggest financial incentive to do this work. So the challenges being in that place are we don't know most often what the true treatment plan is for a particular member that we're trying to assist. We don't have access to electronic medical records for the most part, although that is also changing. But there's no reliability about access. So unless we pick up the phone and call a provider, a primary care provider, a specialist provider, or a hospitalist, or who, all those people that are involved, and even if we were to do that, the likelihood that somebody's going to answer the phone is really it's not very high. And so our biggest challenge is operating, blindly, basically, trying to do what we can to support this member, but not knowing what the true comprehensive treatment plan is, and then also not always knowing, are we duplicating services? Are we filling a gap? And we're trying to fill a gap, but there are so many people often involved. There's perhaps an ADS contract nurse that's visiting the patient. There might be home health that's been ordered. There's a hospitalist that's created a discharge plan. There's a primary care provider who probably doesn't even know the patient's been admitted and discharged. So it's it's like it's an operating blind. So the exception to that, and why I know that this is something we need to work on, is that we have providers like Jane who actually call us and say, oh my God, if we don't do something, if we don't get the macaroni and cheese out of this guy's cupboard and he has one more serving, I swear to God, he's going to end up back in the hospital. So she is the best risk predictor model. I can guarantee it. And it's great. I mean, she will call and she will let us know exactly what the patient's issues are, what she believes. She'll even, I've even gotten, it's going to happen on Friday if you don't get to him tomorrow. Like I'm just, I'm waiting. He's going to admit on Friday if we don't get to him today. And it's phenomenal. But to be able to respond that quickly, that's been a real challenge for our health plan case managers. They have caseloads of 75 people or more that they're trying to assist. Not all that are have been recently discharged, but they do a lot of supporting of our members, and so we haven't been able to respond quick enough until we started to design these community outreach teams, these hotspot teams. Their job, they don't have the 75 patients that they're trying to assist on the telephone. Their jobs are to basically, we think, as we envision them and design the program, are to really be nimble and flexible and to be essentially in the community, in their cars, traveling back and forth, assisting a very high-risk population. Now, obviously, we have to deal with windshield time, and we know that their caseloads are going to be lower, and so we're going to have to do a really good job of learning about segmenting the population and providing this really intense service to those patients that most need it. But anyway, I'll stop there. So that, I would say, from a health plan telephonic perspective, the issue is really working blindly and not having good information flow.